I'm not going to lie, when we started this project in early 2024, I thought we'd be done in 6 months. We're now in late 2025 and we're just hitting our stride. The healthcare network we worked with spans 3 hospital groups serving about 3.5 million people. On paper, they'd emerged 5 years ago. In practice, their systems were still completely isolated. Here's what that actually meant. An elderly patient comes into the ER after a fall. The doctor can see she's allergic to penicillin in their hospital system. Great. What they can't see, the home safety assessment social services did 2 weeks ago, that she's on experimental chemo from the cancer center across town. Her community pharmacy records showing she's not actually taking half her meds. This isn't theoretical, this happened regularly, and yes, people got hurt because of it. They already had integration infrastructure, an interface engine processing millions of HL7v2 messages daily. The problem? It was all point-to-point connections and push-based messaging. Think of it like this. If someone sent you an important email 3 months ago, but it got caught in your spam filter, that information doesn't exist for you. That's how their systems worked. The real headache was connecting the social care department. Their modern integration was a custom VPN tunnel that converted CSV files into HL7 messages. It took 3 developers 2 months to build. We had 200 primary care clinics that needed connecting. Do the math. The research team had it worse. They wanted specific data points, tumor sizes, biomarker values, but everything was locked in PDF pathology reports. Someone was literally copying data into spreadsheets by hand. First question everyone asks, did you rip out all the old systems? No, absolutely not. That would have cost tens of millions of dollars and taken years. Instead, we built what's called a FHIR Facade. Think of it as a translator that sits on top of the old databases. The legacy systems stay exactly where they are, but now, when someone makes a modern API call, like get on patient/12345, the facade translates that into whatever arcane SQL query or HL7 lookup the old system needs. This worked great for simple data. For the complex oncology stuff, we needed something heavier. Pathology reports came in as PDFs, XML files, sometimes even scanned images. We built a pipeline. Ingestion, reports flow through Kafka streams, parsing, ETL service rips apart the PDFs and XML, FHIR mapping, convert to proper FHIR resources, patient, observation, specimen, anonymization, strip personally identifiable info before research access. Sounds clean when I list it like that. Reality? We spent 3 months just figuring out how to reliably extract tumor dimensions from PDFs because every pathologist formats their reports differently. Before we could share any clinical data, we had to solve the "who is this person" problem. Hospital A knew Martha J. Jones, ID 111. Social Services knew Martha Jones, ID 999. The Cancer Center knew M. Sue Jones, ID ABC 7734. We implemented a master patient index using FHIR's patient resource and the match operation. Now, when you query for a patient, the system finds the golden record and links all 3 identities. First time we ran it on production data, we found about 8,000 duplicate patient records. Some people had 4 different IDs across the network. This was the hardest part, and honestly, where I'm most proud of what we did. Hospital systems use standardized medical codes like Sonomi DCT and Low Key. Social care records, free text notes like patient walks with difficulty or needs help with shopping. We used FHIR's care plan and consent resources in ways I haven't seen elsewhere. Care plan. The social worker's support plan becomes visible directly in the hospital discharged nurse's screen, not as a PDF attachment, but as structured, actionable data. Consent. This one's critical. We built granular consent controls so a patient could authorize sharing their HIV status with the hospital, but not with the nursing home administrator. For the free text problem, we ran everything through an NLP engine that mapped walks with difficulty to the proper SNOMED code for impaired mobility.